Hello everyone and welcome back to Clinical Cousins YouTube channel, where today we're going to explain microcirculation. So this is just a fancy word for how fluid moves nutrients in and out of our capillaries. So this is the most important thing in the entire lecture. The purpose of the capillaries is to move nutritious fluid out of the capillary vessel into or in between our cells, and then suck fluid back into the capillary vessel where it can return to our heart. So this is a vitally important concept because you will see disorders of the microcirculation in just about every single one of your patients that you see, especially in America. So here we have a capillary. So on the left here, I've drawn the arteriolar side, right? We move from our left heart to our arteries, and now we're in the big capillary. I've drawn it bigger just so we can see everything that's going on inside. And then we have the middle of the capillary itself. Then on the right side, I've drawn the venule side, right, our venous system, where we're going to return this fluid to our right heart. So we remember from our previous videos that the only reason that blood moves, it's due to pressure. So the heart generates this pressure, and that pushes the blood to where it wants it to go. And we know that blood is pushed from our high pressure artery side to our low pressure venous side, where it can return to the right heart. So we remember that the reason that blood moves so slow through the capillaries is because the total area of the capillaries is actually so large that the blood doesn't have much velocity, right? So instead of maybe putting a finger over our hose and it shooting out really, really fast, imagine that all the capillaries, when you combine them together, it's like a big fire hydrant, right? So it's not going to move extremely fast, and this is good because the whole purpose of the capillaries is to move nutritious fluid out of the vessel, bathe the cells, give them a nice shower, and then they're going to suck that fluid back into the vessel itself. So the nutritious fluid is full of oxygen and glucose, lipids that our cells need to function. Now, the important thing here to remember is that normally proteins cannot move out of the capillaries. Why? Because they are too big and they are too charged. Remember, these little red pieces that I've drawn, they are cells here as well. They're endothelial cells. And these protein planets cannot move past them. So that's what I want you to think of them as, is protein planets that have gravitational pull. We know that planets, especially our sun, right, it has gravitational pull. Proteins are just like planets in that sense that they pull fluid towards them. They want to suck fluid into the vessel. So if I were to take this protein and move it outside the vessel, that protein would suck fluid out of the vessel. Why? Because you can think of it as having gravity. So when somebody asks you why proteins pull fluid toward them, just say gravity. Drop the microphone, walk away. It's not important. What is important is that you know that proteins suck fluid closer to where they are. Okay, so this is the part that people really, really get tripped up on, and I'm going to make it 1,000 times more simple. So just stay with me for 1 minute while I explain this in sort of the more technical terms that you're going to hear. So there are 4 types of pressure that influence how fluid moves in microcirculation in and out of the capillary. Okay, so when fluid moves out of the capillary and bathes the cells, we call that filtration. You can think of the endothelial membrane here as a filter. So when fluid moves out of our filter, we call it filtration. And this is when fluid is passing out of our capillary vessel into the interstitium, right? Filtration, very important. So when the fluid is sucked back into the capillary, when the fluid is sucked back into the capillary vessel, it was in this interstitium, now it's back into the capillary where it belongs, we call that reabsorption because it is reabsorbed back into the capillary. So let's talk about those pressures. The pressures that favor filtration, that favor this push out of the capillary, it's capillary hydrostatic pressure and interstitial oncotic pressure, the IOP. So the pressure that the heart generates when it squeezes is passed along to the arterioles, and this is called capillary hydrostatic pressure. I have it CHP. Okay, in CHP, all it is, I want you to think of a pushing pressure. CHP, what the heart generates, it's pushing fluid out of the capillary. So this means that capillary hydrostatic pressure, it wants us to filter. It wants us to push this fluid through our capillary filter. Now the other type of pressure that wants to move fluid out of the capillary is called interstitial oncotic pressure, the IOP. So this is a fancy way of saying that these little proteins, there are some proteins down here that want to pull fluid between the cells. Now they want to pull fluid out of the capillaries and between the cells to sit in the interstitium. Now there are two types of fluids, or pressures rather, that favor reabsorption, meaning that these pressures, they want to suck fluid out into the capillary vessels. So our first was filtration, our pushing pressures, they want to get fluid out of the capillary. We're talking about pressures now that want to suck it back into the capillary. So the first one of those pressures is the blood colloid oncotic pressure, or osmotic pressure, and the interstitial hydrostatic pressure, the IHP. So the BCOP, that blood colloid oncotic pressure, is due to the presence of proteins in the capillary vessel. So these protein planets, as I call them, they suck fluid towards them and they pull that fluid that's right here, they pull it back into the vessel. Now, there's also another pressure called interstitial hydrostatic pressure, the IHP. So this is the pressure of the cells that are trying to shove fluid back into the capillary. And normally this is not significant, so we're going to ignore it for now. So we have our four types of pressures. It's kind of like a long math equation. We have our four types of pressures, and they are all pushing and sucking fluid all different places. But what is really going on? What is important for you to know as a healthcare practitioner? Well, how do we determine whether fluid is going to move in or out of the capillary? Well, what we do now is we're going to add up all of these pressures, and then we're going to calculate this net pressure. Remember, net is what you have at the very end of the day. So how do we know what the net pressure is? Well, right now I'm going to focus on the capillary hydrostatic pressure. The pushing pressure out of the vessel that we talked about is generated by the heart. I'm going to focus on the capillary hydrostatic pressure and the blood colloid oncotic pressure. That is the protein planet pressure. It's the sucking pressure. So we're going to focus on one pushing pressure and one sucking pressure. So these are the two most important pressures, and the other ones really aren't significant unless you're in certain clinical scenarios or your patient has a certain disease. So let's start on the left side. Let's talk about this arteriolar side. So we have the capillary hydrostatic push pressure, and at the beginning of this capillary, it's about 35 millimeters of mercury. And as it moves to the venular side, it takes energy, right? It takes energy to push this fluid, so it actually decreases to about 15. So what wants to suck fluid back into the vessel? What wants to suck fluid into the capillary? This is the blood colloid oncotic pressure. Remember, the BCOP stays the same because these protein planets, like I said, they're charged. They don't move out of the capillary. So this means that the BCOP is going to stay the same throughout the whole capillary vessel. It's going to stay at 26, and this is super, super important. So what happens on the arteriolar side? We have our capillary hydrostatic pushing pressure is higher than the BCOP planet pressure. So we have push is greater than pull. So what are we going to have? We are going to push fluid out of the capillary. So what are we going to have? Yes, we're going to have net filtration on the arteriolar side. Very important. So the fluid is being pushed out of the capillary. What does this fluid do? It goes and it bathes the cells. They need this fluid, but this takes a lot of energy. It's moving from here to here to here to here. That takes a ton of energy. So at the venule side, we're going to have a lower push pressure. We're going to have a lower CHP, right? We're going to have a lower capillary hydrostatic pressure. Now remember that BCOP, it has not changed this entire time. So at the end of the capillary, that we're going to have that BCOP pull pressure that is higher than our CHP push pressure. So what are we going to have at the end? Yep, we're going to suck the fluid back in. We're going to have a net reabsorption of fluid. So what has really just happened? Well, at the beginning of this capillary, the fluid is pushed out. Then it bathes the cells. They need this fluid. And then, conveniently, it gets sucked back into the capillary And where does it go? Well, we know it's going to be returned to venules, veins, and eventually to the right heart. Okay, so how can we use this information clinically? Well, if our capillary hydrostatic pressure is too high, like with hypertension, then we can have too much push pressure and we will actually have excessive filtration of the capillaries. We're going to have way too much. We're going to have so much push pressure, we're going to send waves and waves of fluids into the interstitium. Okay, well, what if we have too little BCOP? So most of your patients that are coming in, they're going to have what's called hypoalbuminemia. So that means that they have low albumin. They don't have any of these planet proteins that we're talking about. So they're going to have low albumin in the blood. This means that they're not going to have enough protein planets. They're not going to have that sucking pressure. So when they don't have that sucking pressure, they're not going to have reabsorption. So what happens when you don't have reabsorption? This fluid is going to stay in the interstitium. So if it gets bad enough in your patients, they're going to appear very, very, very swollen. They're going to have what's called weeping edema. And this is what happens when your client's skin will just start to leak clearish fluid, and they might have little sores all over their body. They're going to start to weep. They're going to start to cry this fluid out of their skin. So that brings us to our next point. We're going to talk about the two not so important pressures. Now, these can become important in different clinical situations. So the interstitial hydrostatic pressure is something that we can control pretty easily, in fact. So for example, when we put a compression stocking or any type of compression sleeve over a person's limb, we are trying to increase this interstitial hydrostatic pressure. We are trying to shove, imagine my hands are the compression stockings, we are trying to shove this fluid back into the capillary so that it can be returned to the heart. So lastly, let's talk about that interstitial oncotic pressure. So let's say that there are some protein planets that decide to leak into the interstitium between the cells. Well, this is going to suck even more fluid out of our capillary. Now, if it stays in between the cells, this is a bad situation. We need to have fluid come out, but we also need to have fluid return to the capillary vessel. So this brings up our secret agent, the player who is on our team that helps us out, and I'm talking about that lymphatic system. See, we have a little lymphatic straw that is in between our cells. It helps suck some of this fluid and some of this protein back into our venous circulation. So the lymph vessels help us suck that protein, suck that fluid into the lymphatic system, which then dumps into the venous system right before it reaches our right heart. So it's going to do this by eventually dumping into the thoracic duct and then our venous system. So how do we do this? Well, the lymphatic system gets fluid pushed into it, right? So it gets fluid, it sucks up some of this fluid, and then when we contract our muscles, it also contains these one-way valves. So this doesn't allow fluid to go backwards. These one-way valves, once it passes the valve, it keeps on going until it gets to where it needs to be. So in this way, the lymph can slowly return some of that excess fluid and proteins to our venous system so that we don't have edema. So this is a very important player. Now, one of the most famous examples of lymphatic drainage impairment, so when this system is not working properly, is when a patient has lymph nodes removed due to metastatic cancer. So when you remove some of the lymph nodes from the lymph system and some of the vessels, this means that our other lymph vessels have to pick up the slack and return the other fluid. So they can get backed up. So imagine we removed this entire vessel, it's not there. Well, that means that we're going to have some accumulations of fluid, and this can result in what is called edema, which is too much fluid in the interstitial area. Also, if you have a worm infection, filariasis, the worms can actually get stuck in the little lymph vessels, so these worms can clog up these lymph vessels, and it can result in massive edema called elephantiasis or elephant foot. I mean, it is like you couldn't even imagine how big it is unless you actually saw it. So what have we learned today? Well, we've learned that when fluid is pushed out, it is filtered, and this happens on the arterial side. And what happens to this fluid is it's going to bathe the cells and the nutrients that they need before it is returned on the venule side, where it is reabsorbed back into the capillary vessel and via the lymphatic system, so that it can be returned to the heart, so we can do the whole thing all over again. So as always, thank you so much for taking the time to learn with us today, and I hope that you like and subscribe for more content. Thank you.